My name is Melissa Williams, and I'm the Director of Grassroots Advocacy and Partnerships here at National Patient Advocate Foundation. And as the title of the webinar suggests, we're going to focus today on NPAF's approach to regulatory advocacy and let you all have a better understanding about the important role that you can play. Our presenter is Marian Grant, NPAF's policy consultant.
Welcome, everyone. Good afternoon. Thank you for being so interested in a topic that I think most people have no idea about. But I'm hoping at the end of the hour you will understand why it was so important that you are here and why your participation in this process is very important as well. So, a little bit about me. I am first and foremost a practicing palliative care nurse practitioner. I see patients at the University of Maryland Medical Center in downtown Baltimore, but I only do that a few times a month. Most of the time, I am a health policy consultant, and I work for clients like NPAF and this wonderful team. I also am a consultant for the Center to Advance Palliative Care and a couple of other national advocacy organizations. And I would say my specialty is serious illness and obviously from my work with NPAF, interest in financial health. You might wonder, okay, so how did a nurse practitioner end up doing policy work? And that's because in 2014-15, I was a Robert Wood Johnson Health Policy Fellow, and I had the privilege of working in Nancy Pelosi's office. That is a picture of me with the then leader. It was an amazing experience. I also extended the fellowship, and I worked at the Center for Medicare and Medicaid Innovation. And then after that, I kind of started to work for clients doing policy consulting, which has been a great combination for me because I am in a previous career, I was a CoverGirl marketing executive. And I enjoyed working with cosmetics and supermodels. But it was my work as a hospice volunteer that made me decide that I was going to go to nursing school. And but now that I'm doing policy, it's all kind of come full circle. All right, next, let's dive in a little bit. So one of the things we wanted to do is a little pre and post testing. No one is going to give you any scores, but I wanted you to think about, because maybe you've never thought about it before, who decides what the programs, the Medicare programs or the Medicaid programs, who decides what they will cover? Like, how do these things come to be? And so your choices are, is it Congress? Is it government agencies like the Centers for Medicare and Medicaid Services? Is it the president who can issue executive orders? Is it the courts like the Supreme Court or federal courts or even state courts? Is it the states? Because, you know, we have a federal system, but it's a system of 50 states and 7 territories. Or is the public part of who decides about programs for Medicare and Medicaid? So you also have the option of any of these individual choices and all of the above. And on the next slide, Melissa will show us what the correct answer is, which is amazingly that it is all of the above. It isn't any one entity, and the public plays a role. All right, let's talk a little bit more about regulation. And in working with the team at NPAF, we realized that a lot of people, when you talk about policy, or you talk about like governmental policy, people assume we just mean laws and legislation. For those of us working on a national level, you assume we just mean Congress. But there's actually a gap between a law that gets passed and then the health care you and others can actually get. And it's that gap that we're going to talk about today because a lot of people don't know about it, but it is a place where we can practice advocacy the same way as we do when we work with Congress or other legislators to try to make changes to healthcare. Next. The thing to realize is that the law is only a starting point. So I'm going to take you back to probably grade school. You remember, I'm just a bill. Now, I'm not allowed to sing all of it because of copyright things, but you understand perhaps reference to I'm just a bill. And you saw in the video that the bill gets passed, and then what? Well, in reality, passing the bill is only the first step in a multi-step process, and it's the place where the real work starts. So, you can see that the first step is that a bill has to be passed. It has to become law, and that's a part all of you know, right? And in some ways, it's the part that changes the care you get, maybe less than other things that happen. So a law gets passed, then what? Well, it's just a document, right? It's just words in a book. It doesn't do anything on its own. So somebody has to turn that law into, well, what is it going to mean in actual clinical practice if we're talking about health law? And the third step that we're going to cover today is that it's regulations that kind of make that law real. Laws only become real when there are regulations that are written for them and implemented for them. And regulations, you're thinking, oh my gosh, that doesn't sound exciting. And it can be, but they are really, think of them like the blueprint. They are what government agencies use to modify changes to the care that you can receive. So we have this graphic up at the top of the slide that we came up with, which is where the I'm just a bill is holding hands with the regulations, which are also documents, because together that's how we make changes to healthcare. All right, next. So a little bit about how regulations get made. And again, you don't need to know a lot about this, but you do need to understand that we all, as members of the public, play a role in this process. So first, on a federal level, federal agencies turn laws into regulations. And you have a seat at that table. You might not have known it, but you do. So a law gets passed, and it's then handed off to the agency responsible for it. So if you pass a law about airline safety, it goes to the aviation agency, right? And if you pass a law about drugs, it goes to the FDA, right? The department that is responsible for that. For healthcare, it goes to CMS, the Centers for Medicare and Medicaid Services. And they actually take the law and they figure out, all right, well, what changes do we need to make to federal regulation to insert any changes in this law into those regulations? And they've got to be specific and they have to be actionable, right? They can't just be fluffy ideas because somebody has got to use that to tell hospitals how to operate, or physicians how to operate, or insurance companies how to operate. The agencies write a regulation as a proposal, and then by law, they have to open it up for 60 days for a public comment period. And that is where anyone can submit a comment. Typically, these are comments that are submitted by organizations like NPAF and lobbying firms, trade associations, but those comments are more powerful when they include real life stories. And so that's where your stories really matter. We can quote statistics, we can quote evidence, we can make a persuasive argument, but your stories help us make that argument even more powerful. After the comments are submitted and there's a deadline and you send them in to the federal government, they actually are reviewed and synthesized. And they look at every comment they get. Now, I don't know that they spend a lot of time on every comment, but they do. They are responsible for reading the things that come in. Now, some federal regulations, proposed regulations, might get a few dozen or a few hundred comments. Others, like a proposed regulation we commented on a couple of weeks ago that is going to, by the Office of Management and Budget, that wants to change how federal grant funding takes place. No one thought changing it in a good way. I think they got like 500,000 comments. So it's pretty amazing. Now, in the old days, somebody at the agencies had to literally read those comments and cut and paste them into a chart so that they could take a look and see, oh, most people are in favor of this, or most people aren't in favor of this. Now, the agencies are pretty honest that they are using AI. But that's not bad, because if you get 500,000 comments, AI can go through them and say, okay, 60% of the comments said this and 50 said that. And so that's hopefully a better way that they can understand the input that they get. Some of the comments get acknowledged when the final regulation comes out. So, okay, there was this interim proposed regulation, there's the 60-day comment period, then they get the comments, they read them through, and then they put out the final regulation. And they often acknowledge the comments in those final regulations. They'll say, most people were in support of this proposal. Or sometimes they'll say, most people were not in support of this proposal. And they will summarize what the general gist of those overall support or overall not support was. So that confirms that somebody is paying attention to these comments. But occasionally they will say, what one commenter said, and then they will either summarize what the commenter said, or they will quote what the commenter said, which to me suggests that they are not only reading these, but they are paying attention to them. And so when an organization has a comment acknowledged like that, that's a pretty good sign that somebody at the federal agency thought it was important enough that they wanted to point it out in the final regulation. And then that becomes part of the enduring record of the government. It actually goes into a place in the Congressional Library where all of those things get captured. Sometimes, in addition to putting out proposed regulations, government agencies put out requests for information. And these are great because they signal that the government is interested in something. So they might have put out, they didn't, but they might have put out a request for information about navigation services. Maybe 2 or 3 years ago, they could have said, we're thinking about doing some regulations for navigation services. Whoever submits a comment, can you respond to the following questions? And this is a real chance to educate them because they want to be educated. Now, the requests they take the information in, and sometimes you see the reflection of what they learned in the next year or the year after that. And most regulations are updated on an annual basis because, they have to change pricing because of inflation, or they have to change things because of legislation. So sometimes the next year or the year after that, you will see the response from the request for information acknowledged. All right, next. So I am here today with my partners in crime, most particularly Rebecca Kirch. And what we do on your behalf for NPAF is we are part of this ongoing dialogue with the federal government about regulations. And we are in touch with them sometimes in between when regulations are introduced, because they're our government, right? You can ask to talk to the government. You can ask for meetings with the government. And Rebecca has had a number of interactions lately with parts of CMS where they have said, "Oh, they've had a meeting and the agency has said, "Hey, we want to understand more about this." And so she has sent follow-up information to them, which really confirms that we are in a dialogue. We monitor proposed regulations and we comment. We comment on the big Medicare regulations. And we always do that on behalf of patients and families. We are looking for every opportunity we can find, and sometimes we make our own opportunities, but we're looking for every opportunity to advocate for financial health, because that is so important. And it's become really important lately because finances have become hard for us. You know, gas is expensive. We've had higher inflation. Groceries are expensive. So people are all of a sudden really starting to struggle, as you and others well know, to pay for medical care or to pay for health insurance or, you know, to get the preventive care they need and try to stay out of the emergency room. So we are advocating on behalf of regulations that would help people to have better financial health. And every chance we get, and as I said, sometimes we make our own chances, we are advocating for needs navigation. And below is the definition that we are using when we advocate for needs navigation. This is a definition that was created with input from you and other patients. So it is provided hands-on by individuals skilled in communication and resource coordination. Needs navigation helps secure access to safety net services and other responsive assistance, personalized to preserve patient and family financial health. So we have been putting this in our comments on federal regulations for several years now, and we are starting to make progress. Next. Most importantly, one of the biggest regulations every year, and it is a regulation, it is not a law, is called the Physician Fee Schedule. This is a list of all the services that Medicare pays for and what they pay for them. Not terribly exciting, I will give you that. But it is a place where new services are often introduced. And there was, in the last year's physician fee schedule, and this is one of the biggest of the regulations of the year. I mean, probably 20,000 people respond to this regulation. There was a new heart failure model, and we looked at it and we said, you know, that model would really benefit from the addition of needs navigation. So like we always do, we included that in our comment letter. And lo and behold, the final physician fee schedule on page 1038, and this is like a 1,900-page thing, a few commenters recommended that CMS should consider beneficiary incentives and went on, and needs navigation assistance. So that was the first time they played back to us what we have been saying to them, which is, hey, we hear you. We hear you, NPAF. You are talking about something called needs navigation. We read about it in your letters, and we think that's interesting that you suggested it for this model. Now, did they make it a part of the model? No. And I mean, things don't quite always work out that way, but just the fact that they acknowledged it is a sign that somebody thought that it was important. And who knows? It might show up in a future regulation as part of a proposed regulation. All right, on to our next example. So a little background before we get to the example, a little background. So up at the beginning of the webinar, I talked about Medicare and Medicaid. Like, you all know exactly what those things are. So I wanted to just take a moment, a message from our sponsor, to say that they are different programs managed by different regulations, and different people are in charge of these two programs. So Medicare, What it is the federal health insurance for people who are 65 and older, and some younger people with disabilities or who are on dialysis. It is managed by the federal government. This is a federal program paid for by Medicare, well, paid for by our taxpayer dollars, but paid for by the federal government. Medicaid is health coverage for people with low income and certain other eligible groups, including children. And this is a program that is managed both by the federal government and state governments jointly. So if you're talking about Medicare, it's entirely the federal government's control. They put the regulations out, they make changes. But Medicaid is something that has to be done in coordination with the states. And that is one reason why the variability of Medicaid can be seen state to state, because even though there are some federal rules for Medicaid, New York might have a different program than Arkansas, might have a different program than Texas. So there is that state variability. All right. Now on to the next example. All right, we thought we would take a real life situation and kind of walk you through what's been going on. You may remember last summer, the big bill got passed by Congress. So this was a federal law that got passed. And it was paid in it. They needed to find money to pay for maintaining tax breaks. And you might have seen some of those tax breaks this year when you did your taxes back in April. But it was a lot of money that they needed to find. And unfortunately for many, they decided that the way to find that money was to cut aspects of the Medicaid program. There are people in Congress who feel that Medicaid is something that should be really only rarely available to people. I think we would disagree with that. And they are looking for every chance they can to reduce the size of that program. So that's what happened. The law got passed. That was a done deal. And once a law gets passed, unless another law is passed to undo the first law, it is law, right? We say that it's law. So at this point, it then moved over to CMS, Centers for Medicare and Medicaid Services, because they're in charge of Medicaid regulations. But now they had to take this law and turn it into actionable stuff. And there was, the law had a January 2027 start date in it. So the agency did not have a lot of time. You know, they got the thing passed by the president, I think last August. And immediately they had to start working on pieces of this because the states were like, hey, we're going to have to make these changes in January of 2027. And they put out some preliminary guidance in December. And then a few weeks ago, they put out the formal regulation for this. Next. But here is where the plot thickens. Because the law can never be detailed as much as regulations need to be. And it left room for the agency. It left some wiggle room on the part of the agency. And that has become the latest story. So the laws, one of the things about the law is that it requires people in states that expanded Medicaid. So that's 41 states. And the expansion allowed more people to get access Medicaid than that had historically been the case. They still couldn't be wealthy. But they didn't have to be as poor as people previously had to be to get Medicaid. And but the law said, well, we don't want you might remember, we don't want able-bodied people to just get free health care. So even though the fact that many people who get Medicaid are already working, the law required that people prove that they were working or that they were enrolled in school, or that they were engaged in volunteer activities, so that they could keep their Medicaid. And obviously, there are some people who can't work or can't go to school. And so the law allowed for some exceptions, some exemptions, but they left those details up to CMS. And CMS, unfortunately, went further than what the law required, and made it harder to get an exemption, which was really unfortunate because the guidance they sent out to the states in December didn't say that they were going to do that. So come June of this year, the states get this new proposed regulation, and they're like, what? Wait a minute. We were already building systems that were going to exempt the people that were in the law. Now you've added additional things. And there is some debate about whether CMS really has the authority to do that. They're only able really to do what's in the law. So 25 states have sued CMS saying, you guys added stuff in here that wasn't in the law, and you're not allowed to do that. And the first court hearing was just a few days ago, and the judge said, well, I'm not going to stop things, but we're going to continue to go hear this case. So it's not really clear what's going to happen. The regulation also went out, as all regulations do, with an opportunity for the public to comment. And we wrote pretty critical comments. We were not supportive of most of what was in this regulation. And we were not quibbling with what was in the law because there's no sense arguing, it's the law, but we were arguing with what CMS had added to it. We are now waiting to hear what CMS is going to do about that. We fear that they are not going to make a change. The regulation was issued as an interim final rule, which kind of sounds like being half pregnant, right? But they are probably going to finalize it the way they proposed it. And now it's just up to the states because there is some discretion on the part of the states. So now some of the advocacy is turning to the state level. Okay. So that was one recent, somewhat painful example. Next. I am going to do this section with Rebecca Kirch because in addition to regulations or within regulations, there are what we call quality measures, because more and more the federal government is trying to make sure that the care that is delivered is good quality. And the one way to do that is to have quality measures. But there aren't a lot of great quality measures. And CMS a few years ago awarded money to have a new quality measure done for community-based palliative care. And Rebecca, do you want to jump on and talk about how NPAF was part of that process?
Sure. I guess the most important part of the opportunity was that quality based on whose quality are we measuring, right? And here, NPAF always stands for, well, what people tell you is quality is what we should focus on, not what bureaucrats do. So we were grateful to be part of a collaborative project with the professional community that makes up the palliative care workforce. And I did answer the question in the Q&A, and I'm so sorry our chat isn't working because it's really frustrating for us not to be able to interact with you that way. We're so accustomed to the pleasure and privilege of seeing who's here and where you're from, and that's a glitch we'll have to fix for next time. But palliative care is focused on helping support people's quality of life alongside their disease-directed treatment. And we brought some patient advocates from our Grassroots network into the expert advisory room in the case of developing this new measure that the Center for Medicare and Medicaid Services invested money in having experts produce. And those experts included real people, patients and caregivers with lived experience from the NPAF Grassroots Network. And in that room, together with those who are clinicians like Marian, who's a nurse practitioner. Marian, I think you were even on the
I
teacup, right,
was,
for this, right?
yes,
You were there in the room when it happened.
I was in the room when
Um,
it happened. Yeah.
and and what we talked about there was what are the patient reported outcomes that matter most to people right now in the context of making the health system work better, and what we know about what palliative care is trying to do to make things better for people in their healthcare experience. And the secret sauce of palliative care, as we've been told and we've experienced, if you're lucky enough to get good palliative care alongside the healthcare you're getting, is the communication skills that help listen, ask and listen to what matters most to you, what you're prioritizing in the construct of your health experience. That's frankly where NPAF has also learned by listening to our grassroots about the importance of financial health, as we say now, as a vital sign. It's something so important. But here in this case, people said, that I feel heard and understood is a key way that I measure whether or not I like what's happening in my clinical encounters, in my doctor's visits. I want to know that I'm being heard, I'm asked about what matters to me, and that people are listening. And that can actually become an accountability measure that's associated with how we pay people to deliver what's called quality care. So it's not just a loosey-goosey phrase to say quality care. It really means something grounded in what patients and caregivers have told us. And that became a measure that is validated, hitting on these 4 points that are featured in the slide, that a patient can report or a caregiver can report a little bit of a report card on how they experienced communication with their doctor, their nurse, the people in their sphere of care, that they felt that they saw me as a person, not just as a disease or a body part, right? That I felt like my interests and what mattered to me were at the forefront of the conversation and the recommendations we made. So it's patients and their lived experience input that made this measure be created, validated through research, and start to become part of how the Center for Medicare and Medicaid Services in Medicare pays for healthcare through the Medicare program.
Yes, and this is a measure that we have obviously feel great about and feel ownership for it. But every chance we get, which is pretty much every time we comment on proposed regulations, we say, this measure would be really good in this other program as well, because Felt, Heard, and Understood was developed just for community-based palliative care, but it has subsequently been expanded into measures for cardiology and oncology and I think pulmonology. So we are starting to see that it is being more and more broadly used because there aren't a lot of patient reported measures where the patient voice is directly heard. And this one would be appropriate for any part of healthcare, right? So we keep advocating for it, and they slowly keep adding it to new things. Next. I think Melissa's going to come on, and if Rebecca, if you want to come on camera too.
Yes, I will jump in. I think before I even go over this slide, Marian, I wanted to lift up a question that came in through the Q&A, if that's okay, because I think I think you kind of touched on it, but I think this is a pretty great question. This is from Joel Clark. Dr. Grant, thank you for this presentation. The law states there is a required 60-day comment period, but is there any regulation stating that they have to listen to those comments or truly change regulations? In today's world where it feels like those in power aren't listening, how do we navigate this beyond continuing to use our voices and stories? And from your experiences, how responsive is the federal government in its current state? And I think the question may have came before you provided these examples, but if there's any other color you'd like to add.
It's a great question. I would say it really depends on the administration, on who is running the agency, and who is reading the regulations. I have been doing this work now for 10 years, and I have seen proposed regulations come out, get a lot of negative feedback or suggestions for how to make it better. And then when the final regulation comes out, they can be changed. So sometimes the administration is taking very seriously the feedback that they get. I'm not sure that that's the case for the current administration. You know, we've only been commenting on rules for a year and a half now in the second Trump presidency. They seem pretty wedded to what they're doing. You could say that it is just then kind of performative, that they're just, yeah, the things go out for comment. They look at the comments, they blow them off. I don't know. I mean, they aren't changing the final regulations right now, but here's the thing. You've got the people at the top of these agencies who are politically appointed, right? They were appointed because they are supportive of the current president, the current administration. But underneath them, if they haven't been fired by Elon Musk, there are hundreds, if not thousands, of career bureaucrats. And those people aren't going away. And so we actually have seen in palliative care that somebody who started low in the Biden administration is now a high-level person in the Trump administration at CMS. But what he learned about palliative care when he was in the other position, he has now taken to his high-level position, and he is starting to do things on behalf of palliative care that frankly we never saw before, and we didn't get with the Biden administration, we didn't get with the Obama administration. So it isn't always the case where they put something out, everybody hates it, they change it, and we move on. Sometimes they look at all of the negative feedback and they decide they're going to do it anyway. But that also is something that could be, unfortunately, something that could be used in a court case. So this OMB rule that we commented on about funding the agencies, if 500,000 people commented, and Politico did an analysis of the comments because these are public. I mean, when we upload our comments, anyone can read them. So they took a look at, not all 500,000, but they looked at a bunch of them. They said, these are all pretty consistently negative. So if they finalize the regulations despite having all of that negative feedback, that could be a lawsuit. Somebody could say, you know what, are you serious about getting public information? Because if you aren't, then let's not waste everybody's time. If you get negative feedback, or if you get feedback about things that need to be changed, you need to be thinking about that. So we will see what happens.
I will say too, Marian, I think it's so important. This is where the reinforcement of how stories from real people cuts through that clutter. It's much harder to squirm out of your seat in making decisions when you have the real impact of these policies front and center in the comments. As we did with Medicaid, we shared some specific stories that you all submitted in our Medicaid comments that make very clear these are how, it's not just an implication, it's a direct causal effect of what your policy is doing that has a perverse impact that's not what you intended. So every time we get stories that we can get from all of you and people like you to insert to illustrate the policy point, we do that pretty strategically and with precision. And we've earned a reputation for those career staff who've been in the trenches at CMS for years, fighting the good fight. And they aren't going anywhere, as Marian said. We develop relationships with those folks because they know they can count on us at NPAF and the Grassroots network that we've built to share, here's how it is in the real world. And what this particular lever that you're pulling on will do to people, to health systems, that is not what you want. And so every time we have that opportunity, those data points really can be very influential, even in a time where it feels like everything's a fait accompli and it's all pre-baked. I would say it's rarely truly pre-baked. Even if the rule comes out final, unchanged, we've established a record that we can always go back to and push on those buttons again and again and again. And it can help regulatory process change over time because nothing's set in stone. These rules get rewritten year after year with tweaks where we can come back and say, that really didn't work. Here's the
Yeah,
evidence. Let's adjust it here to fix this problem.
absolutely. And I think as you're talking, Rebecca, it reminds me this is not a fast process, just like passing a law is not a fast process. It's very rare that something gets introduced and gets passed the same session. Usually it takes years and years and years to build support for something and finally get it passed. And then the same thing with regulations. We could be talking about something, we could be talking about needs navigation for the next 3 or 4 years. And then finally, something might work out. Just the right people, the right time, the right leadership, and there we are. It might actually get added to a regulation. So you have to be kind of an optimist to do this kind of work and be pragmatic about the fact that even though we write wonderful letters, including your powerful stories, it might not change anything in the short term. But you got to believe that long term, the ripples, will eventually end up becoming waves.
Thank you for addressing that question. I thought it was just such a really timely one, and I think the color you both added was really important. We do have a couple more questions, but I wanted to address the first question that came through because I think it's reflected on this slide in terms of what can we do as members with NPAF? Are there paid volunteer advocacy opportunities? And I will just acknowledge that, as someone who was started off at my time with NPAF as a volunteer, sometimes it feels like just signing up to be a part of this movement. Um, Sharing stories may not feel substantial. I hope this webinar so far indicates that your stories and your perspectives are really, really important. We do listen to and read every single story that comes through. And where it makes sense, we integrate them into our comment letters. We integrate them into conversations that we are having with policymakers, those at CMS or beyond. And I think first and foremost is I know many of you are already part of our grassroots network, but looking for others to join our cause, recruiting others to sign up as well, registering and voting, making your voice heard in that way. There are times where we have action alerts and we want you to write directly to your legislators. Answering that call is one thing that you can do. And most importantly, as Rebecca just acknowledged, sharing your story is incredibly powerful because we do take those stories and include them in our comment letters. We include them in future events that we have, whether it be policy consortium, and it just makes the issue a lot more real. And so we can't impress the importance enough of doing these actions. And I think before I just turn to the
And Melissa,
last comment, yeah, go ahead.
just one thing to say. If you are curious about our letters, I believe that our wonderful Shonda Day uploads every last one to the website. And so if you want to read powerful stories, take a look at our most recent letter about Medicaid. We opened with a powerful story, we closed with a powerful story, and they came from you. So they are there for your reading if you are interested.
Thank you, Marian. I we have, I think, a number of different letters to upload. So they are making their way up to the website. But yes, we do try to include those our own comment letters that we author, as well as ones that we sign on in a larger coalition. So those are there as well. But I want to just, I think you have some post-event questions,
I did.
Marian, or post-quiz, I should say.
Yes.
So just want
Right.
to give you the opportunity to go through that.
So this question should look familiar. Who updates Medicare and Medicaid policy? And your choices are Congress and laws, government agency regulations, executive orders, the president, the public, all of the above. So think about what your choice would be. And next, it is still all of the above. All right. Question after that is, can patient stories affect how programs like Medicare and Medicaid get updated? Your options are yes and no. So what are you?
Or heck yes.
No fair, Rebecca. You gave them the answer. All
I
right.
hedged. Heck yes.
Heck yes. So needs navigation language on page 1038 of the fee schedule is proof of that. Yes. All right. Final question. Can you change healthcare? Yes or no? And the answer is, of course, yes. You have already done the hard part. You showed up to learn how to do that today. And you are many of you, part of our grassroots effort. And we look forward to your participation there and your stories. And we are going to keep fighting the good fight. 2.5 more years. We're in it till the end of this administration and the regulations.
And I want to just acknowledge I guess they're not really questions, but there are comments that came through. And again, we do apologize that oversight of the chat not being active. We do rely on that so that there's some interaction back and forth. And so we'll have to check our settings there. But Virginia commented here that these measures are largely unattainable given the current state of healthcare. The healthcare system is understaffed and overwhelmed, not to mention bound by the insurance industry. Patient advocacy begins with healthcare advocacy. And so just wanted to just read that out loud because I think a lot of people may be feeling the same way that Virginia is feeling. And I know, Marian, you had just acknowledged that having that optimism is necessary here, but I also just want to acknowledge how heavy things might feel at times.
It's absolutely true. You know, I was in New Orleans last week speaking in front of a room full of healthcare professionals, interprofessionals, so social workers, nurses, chaplains, physicians, and they too are feeling the weight, just as Virginia mentioned, of what the atmosphere is like. And we have the compounding issues of immigration policy, what that means for the workforce, especially those who are doing home-based care for people who are bound to home or needing that kind of community-based care, or nursing homes, even the clinician ambulatory care schedule, you know, doctor's visits, and what the grind is to get through the day of seeing volume of patients instead of highly personalized encounters. All of those challenges are, I think, what keeps many of us up at night and gets us up in the morning at the same time, even if you don't have optimism, and it's okay if you don't. All of advocacy is about stick-to-itiveness and resilience, which I know our grassroots network to have in spades, that we want to do what we can. The shared objective is to make progress happen. And sadly, but surely, I have seen in my 30 years of doing this, I think Marian has as well, Melissa, a less long time, but still many, many years, over a decade. We just celebrated her 11-year anniversary with NPAF. Every crisis does also breed the opportunity to make change happen. So even though it's really frustrating, and sometimes nearly unbearable. We also band together, and I have never seen like now, different sectors, whether it's the pharmaceutical industry, the insurance industry, the research academia industry, and health professionals together with patients, all agreeing this is not working. We're looking down the barrel of more not working in terms of the Medicaid changes, plus the elimination of the Affordable Care Act advanced premium tax credits and premiums rising. There is common agreement that what's happening now needs to fundamentally change. There are parts that worked and many parts that didn't. And I don't want to sound Pollyanna or optimistic in the context here, even though I was kind of born that way to be an optimist. I do see strategically always the opportunity for us to make changes where it matters. And we do have reception to the idea of needs navigation as a really important band-aid. If we can make someone be accountable in every care setting as a team to helping ease cost concerns as part of the healthcare encounter, that's a big part of feeling heard and understood looking ahead. If we can normalize that affordability and financial health go hand in hand with access, that's a huge step forward from where we've been, which is thinking that only low-income people have trouble with affordability. No, we all do now. That's become a common concern, which makes a stronger lobby, if you will. That's where the many, many stories matter so much, because backed by the statistics are all those compelling stories. And that's where we can cut through that clutter of nothing will matter, we can't do anything. Stories move past that Eeyore affect of, oh, there's nothing to do. They really move mountains when you get enough of them in the right places. And that's what NPAF's secret sauce is. And what we have superpower to do is get the most compelling stories that illustrate the problem and the solution in the places where there are people who can do something about it.
And I think with that, Rebecca, you really made this segue very easy for me. We invite you all to share your story with us. This QR code that's on the screen takes you to a secure website where you can tell us about how your healthcare experience has impacted your finances or any of the trade-offs that you've had to make. And if you don't have your own story, you can share this link with someone else. We also invite you to register for our next office hours. And I know because of the issue with the chat, we're going to send that link to you all in follow-up. But in our office hours, we are going a bit deeper than we did here in terms of how you all as grassroots advocates can go out into your community and listen for these stories and bring them to us so that we can bring them to the policymakers through the public comment periods, as Marian described in this webinar. So it is a chain, and it really does start with you. And I think that resilience that Rebecca talked about is really the common denominator that I see in so many of the different grassroots advocates that I've had the pleasure of meeting over the last 11 years. The people a part of this network do not take no for an answer. You keep fighting the good fight, and if you somehow hit a wall, you pick yourself back up again and you find another way. And I think that's what makes this group so inspiring. And it's why I just so treasure the time that I get to do this work with you all. And just remember that you all can make a difference.